Hey up everyone, good evening. Thank you for showing up on time tonight, and I hope you're all okay and you've had a good day. If you are following my classes, this is the 15th class under the series of mock clinical practice. This is me, Ghada, El-Abedin, once more, and I'm happy to share with you some of my knowledge regarding neuro-ophthalmology. Okay, so this is the beginning of neuro classes. So we are going to start with confrontation visual field test. And as you know, this is an interactive session. Remember this pen, we are starting our class with this pen and we will gonna end this class with that pen again. Okay, it has an interesting story. Okay, just a reminder that we already finished 14 classes. The first one was like an outline regarding the course. And then we covered oculoplastics topics in 13 classes. So we discussed proptosis and dystopia in 4 classes, ptosis in 4 classes, entropion in 2 classes, ectropion in 1 class, and we have final miscellaneous class, okay? So these are the numbers of the topics and not the number of classes. And now we are heading or diving into a bit more challenging topic, neuro-ophthalmology. And we expect that we are gonna cover it in more classes. So you need to be patient. Again, this is the outline of my course, okay? And if you remember, we didn't cover all the topics in oculoplastics. So I advise you to work on your own regarding, for example, an ophthalmic socket, okay? Lacrimal system, whether we are talking about lacrimal production, lacrimal gland swelling, or drainage, like lacrimal sac issues, eyelid masses, or any swelling in the orbit or the adnexa, and enophthalmos, and be careful about the pronunciation or the difference between anophthalmic socket, anophthalmia, and enophthalmos, okay? So please don't confuse the difference between both terms, okay? So according to a voting that previously posted, what is the most difficult station, the majority actually mentioned the neuro and oculomotor disorders. So, but I started by addressing oculoplastic, this much less overwhelming, and now we are starting with neuro again. And it's not uncommon to have an experience like this. The candidate got the pass mark in all stations except for the neuro. It's really sad. And you must exert some effort in order to pass it with much confidence and much ease. So forget about the past and let us push through and just imagine neuro and strabismus like a puzzle. And as you know, the more pieces, the more challenging is the puzzle. So don't panic and try to be patient and take your time in order to have the best results and you can pass the station easily. You need to study these challenging topics with a relaxed mindset, okay? And don't leave challenging topics until the end, just shortly before the exam, okay? Because it's very difficult to understand and memorize information while we are stressed. So we have the same frame, opening slides, then the test itself, confrontation tests, cases based on previous candidate experiences, the most interesting and my favorite part, quizzes, and then closing slides. And what's new in neuro classes that we have something added, which is called experiments. We are going to experiment some of the tests on ourselves, okay? And experience what the patient sees and what the patient feels. We expect to cover all of these in 4 classes. So this class is all about opening slides. So it's a kind of short class warm-up, but this doesn't mean that it's not important. It's really important because it's like something like you need to warm up and to stretch your muscles before you start working out your body muscles. The same applies here for mind. You need to have like some basics, some refreshment about basic concepts before we start talking about the confrontation test itself. And if you notice here, I don't know if you can see the mouse cursor or not. And here, Yeah, I'm using the laser pointer. If you see here, it's like all are in plural. So I will explain this later. The confrontation actually is viewed as tests, is a number of steps. A number of tests is not only one single step. Okay. So the second class will be about the confrontation test, the video where I explain every step. And third class about the cases, and the last class about the quizzes and the closing slides. Let's start with the opening slides. I'd like to start with something light, which is linguistics. If you check the meaning of confrontation as a word, it's a kind of something called polysemous or polysemy. So it has many meanings. So here we will use the third meaning. It means comparison. The primary meaning actually is you are confronting someone. You are like in a conflict. You are facing someone like police and criminals or gangs together. But we are not using this meaning. We are using the meaning of comparison. So simply you are comparing your visual field, the doctor's visual field, with the patient's field, provided your visual field is normal, of course. Okay. So just view confrontation visual field test as a comparison. So confrontation here means comparison, like CC. All right. So before we start talking about some basic concepts, is it important? So this is my first question to you. And let me know in the chat. Is it important to know how to do confrontation visual test properly or not? So give me at least 2 reasons why it's important to know how to perform a test properly. Yeah, it's important, it's crucial, it's important, but why? Okay, so while you are thinking, so why it's important to know if there are certain topics important or not? Because if we know they are important, our minds naturally become open and willing to exert effort and time in studying these topics. No, I'm not talking about the advantages of confrontation. Why it's important to know how to perform the test itself. Okay, so basically you are saying that in our practice, in order to detect abnormalities, it helps in the diagnosis. So this is in our practice. To detect abnormal finding, it might help us in reaching the diagnosis. This is number 1. Since you are candidates preparing for the exam, so I would say, yeah, thank you. The one who mentioned to clear the neuro station in order to pass the exam, the neuro station, because it's very common to be asked about how to perform a visual field test on a patient in neuro station. So number 1, help us to pass the neuro station. As you can see here, this is copy paste from experiences. This is a candidate from Amman, 2020, like last year. The examiner asked me to perform confrontation visual field test for a 3rd patient. And I just started with the beginning of the visual field, then the bell rang and I couldn't complete the case, okay? And this shows us how it's important to perform it quickly, okay? How to perform it quickly. Another experience from Delhi, here the candidate was asked to do the test on the 1st patient, okay? Use the white pen, asked if they wanted the red, but they said no anyhow. This shows us how to be prepared with your pens, white and red pens. And the last one in Cairo, the case was the same patient, the left eye, okay, he asked me to do the test. The patient was normal. So the examiners wanted to see the techniques only. So don't be surprised if the findings are, like, there is no findings, there is no abnormalities. So sometimes the examiner wanted to make sure that you do it properly, okay? So that's one important good reason to study the test or to do the test properly. And the second importance in our practice, we need to do it on every single patient. It's actually in some places or the most accepted, the standard medical care, ophthalmic care, is to do it on every single patient, regardless of their complaint, okay? Especially if we have an explained diminution of vision. So this is a sheet, like a report, eye examination report. And as you can see, visual field test, if we enlarge it, is part of the sheet, okay? And you have to mention the type of the field test and the findings. And this is a medical report, electronic, from Einstein Eye Institute. This is actually for strabismic unit from the strabismic clinic. And even though it's strabismus, you can find visual fields is part of the here basic ophthalmology exam. So should be done routinely, whether it is relevant or not. This is something for documentation, for medical legal importance. And this is my personalized strabismus sheet. And again, you can find the visual fields, one of the techniques that you should do routinely on every single patient. Okay, so that's why it's really important to know how to do it properly. So I need someone now to volunteer to read aloud the following paragraphs. Reading aloud.
Yes.
Thank you.
Okay. Confrontation visual field tests should be performed on all patients, even those without afferent complaints.
Yeah, exactly. Because simply confrontation visual field is a test of the afferent visual pathway. So even if we don't have an afferent visual pathway complaint, you have to do it. Okay, nice.
Confrontation visual field tests provide a rapid and practical method of visual field assessment that can be performed with minimal equipment and may be the only method of testing readily available. The test is quickly performed and easily understood by most patients. It will identify gross scotomas and has only moderate sensitivity and specificity for identifying small or subtle scotomas. A normal confrontation visual field test does not preclude the need for more automated visual field testing.
Thank you so much. Okay, so I'm going to elaborate on these sentences, but not in this class because I don't want to overwhelm you today. Okay, but here I want to share with you something that reading aloud is a powerful tool. Okay, and you should make it part of your routine or in your preparation for the exam. And it took me a while to realize how it's very useful and how it is important because in the exam, you are going to talk with the patients, with the examiners, and in real practice, we need to speak again clearly and confidently with others. Okay, yes, you can read silently if you want to understand better. Most of us can understand better while reading silently, using our eyes or even moving our lips. But in order to improve your fluidity and build your confidence, you have to read aloud a little bit. Okay. And of course, you notice that some practitioners, some doctors can gain the trust of their patients, even they are not that knowledgeable, because they can speak confidently, they can convince patient about their expertise, about their line of management. Okay, so please do some read aloud practice while preparing for the answers for any questions. Just a hint about the confrontation visual field. So we expect this test in the neurostation, in the OSCE neurostation, and we can divide the test into 3 stages. I compiled them into 3 E's. So the first is something called evaluate, and then express, and finally explain. So again, the first step is evaluate. What I mean by this, so you are going to evaluate the patient. Okay, so you are going to talk. So you are going to talk to the patient, mainly giving patient instructions, a lot of instructions throughout the test, because you need a lot of cooperation from the patient. And as you can see here, this is like a speaking bubble. You are going to speak. And then you're going to report the findings to the examiners. So this is express. You are reporting. You have to practice how to report the findings. Okay, it's not enough to do the test properly. You have to tell the examiner, like transcription, like reporting the findings accurately. Okay, and next, the final stage should be the easiest one. The examiner might ask you some follow-up questions. They might ask you to make a correlation, to come up with a diagnosis, and you are going to speak and answer the examiners. So it's very talkative. You need to be talkative during this evaluation or this technique. And don't forget to be thankful to the patient, because in order to improve the cooperation of the patient, you need to thank them and encourage them, and also thank the examiner at the end. So confrontation visual test is about being talkative. You are going to say please and thank you to the patient many times, because we have a lot of instructions. We will explain this further in the next class. Before I move this slide, do you think which one is the patient and which one is the doctor here, or the candidate? Just to test your observing power.
The candidate is the one on the left, to the left, sitting on the left.
Yeah,
yeah.
Thank you. Because what? So you have to explain, to tell me why. Why you said this is a candidate and this is a patient.
I can see wheelchair.
Yes. Yeah, generally speaking, yeah, the candidate may be disabled, but anyhow, I need you to be very observant, to look at the bigger picture. So the patients may have a wheelchair, may have like crutches, maybe he is hemiplegic, having hearing aids, okay? So you have to be aware of all of these, okay? So try to be observant, all right? Thank you. Okay, so a kind of interactivity and to test your background knowledge about some information regarding visual field. So we have a statement here. I brought two statements. This is the first one. The visual field and retina have an inverted and reverse relationship relative to the point of fixation. As you can see, relative to the point of fixation was written in bold because this is really important to say it, okay? So I need someone to volunteer, unmute, and explain the meaning of this statement. The visual field and retina have an inverted and reverse relationship relative to the point of fixation. If you want to interact in the chat, it's okay.
Yeah, so visual field and retina have an inverted and reverse relationship relative to the point of fixation is because if there is a suppose supranasal retina is involved or there's any nerve fiber layer loss of the supranasal part of the retina, then we'll get the infratemporal field defect. So they are inverse related to each other.
Yeah, excellent. This is the best answer ever because you just give us an example that says everything, okay? Yeah, thank you so much.
Thank you.
Sometimes
Thank you.
providing an example is more than enough. Thank you.
Thank you.
And I liked your way you started your answer by rereading the statement itself. And this is strategy you can use in the Viva. If you want to buy some time, you can repeat the examiner's question. Okay. Sometimes
Yeah.
while you are repeating the question, you're giving yourself some part of seconds to think. Okay. So I like the way you started your answer. Thank you so much. Thank you.
Thank you.
But I'm gonna illustrate this statement in more elaboration using illustrations because I'm a visual learner and I like to use visual illustrations. And because will have a lot of implications later on. And yeah, so this is the right eye. So first, when you see a diagram, you have to think, like, take your time to see, is it the right eye or left eye? So this is the right eye. Imagine you are looking at the screen and this is your right eye. And here is the midline, okay? And the other eye is occluded, the left eye is occluded. Because generally speaking, when we are talking about the visual field, we are talking about monocular testing, okay? So you are fixating on the target because every visual field test, you should fixate on a target, okay? So suppose this eye is fixating on this star, blue star, and here is the visual axis, and the image is falling on the fovea, okay? So this is central fixation. Now, we have an object here, but this object on the right side of the right eye. So be careful about the language I'm using, okay? This object is on the right side of the right eye. And to be more specific, this object is on the right side of the fixation point, okay? So because I always say that, we should always say that the fixation target is the reference point. Now we have target here on the right side of the fixation target. So this object is in the temporal field, all right? And its image is falling on the nasal retina. Now we have object here. It's considered on the left side toward the left or towards the midline. We can say simply towards the midline. So it's like to the left of the fixation target. So this actually is located in the nasal field of the right eye. And this is an etched image on the temporal retina. So as the doctor said, if we have like temporal object in the temporal field, it's image on the nasal retina. So if we have an issue in the nasal retina here, this area is affected. We have the field effect here. The same applies on the other side. By the way, if we have an object here more towards the left, okay, more towards the left, is still in the nasal field of the right eye. This is called in the nasal field, and its image and will be falling on the temporal retina here, extreme temporal. So again, this is an object on the far right, and its image will be on the extreme nasal retina here. Basic concept you should aware of. Now coming to this diagram. If we have now the object very far, like to the left side, and the other eye is occluded, do you think we can see this object? At some point, you can't no longer see this object because of the nose. So the nose obstructs the light ray from reaching the globe. Okay, and that's why the nasal field is limited. Okay, why is it important of saying this? Because some learners or some candidates may put the target very far. Okay, it's like far beyond the normal range of the visual field. Okay, so try to practice that there is a limit for the normal visual field. So don't put your target too far to the other side, because definitely it is not seen by this eye. So even if there is still retina here, but the light ray from this object never reaches this eye because of the nose blocking the ray. Okay, are you following me? So yeah, let's summarize. If we have an object in the temporal field, its image falling on the nasal retina or projected on the nasal retina. If we have an object on the nasal field of the eye, its image is projected on the temporal retina. And actually, this is called reverse relationship. How about the inverse relationship? So now imagine we are looking from above the globe. So we have here a fixation target. And if we have an object above in the visual field, like above the fixation target, so our reference point, remember, the fixation target, if we have an object above the fixation target, its image is falling on the lower retina. And if we have an object in the lower field, its image in the upper retina. Okay, so upper object, lower image, lower object, upper retina. Okay, so this is called inverse relationship. Now it's time to experiment, to do some experiment on ourselves. Now, right now, you can do this test right now, like during the class itself. Close your eyes, but before you close your eye right now, so just close your eyes and then press using your, what we call it, the index finger on the upper nasal part of the retina, or let's say on the globe, in this area. And let me know what happens in the chat. Close your eyes and press on the upper nasal part of the globe by your index finger. And sometimes you make the press intermittent, not like continuous, like you remove your finger and then press multiple times. It's nice to try this. Okay, so what did you see? Yeah. So now you will see something, it's hard to explain, but something glowing, and it's the form of circles. So I can't demonstrate it, but it's like located in the inferior temporal field. This shows the inverse and reverse relationship between the visual field and the retina. Okay. And by the way, this is a wonderful experiment because you see now the retina is stimulated by pressure. And this is a reminder, and this is a reminder that the retina is sensitive to two stimuli, light and pressure. And this explains why when there is a retinal break, during the process of like tear or something, the patient may experience flashes of light. So retina is sensitive to pressure, like shearing forces, and also light. But regardless of the stimulus, the response is in the form of image or light. Okay, nice. So this was the first experiment. I'm showing today 3 experiments. This was the first. Now, a quick test your understanding and your attention during the class. Okay, so I'm giving you some examples. So you have to let me know in the chat every scenario, every patient, what do you think will develop or might develop upper or lower visual field defect based on this inverse and reverse relationship. We have 1, 2, 3, 4, 5. Okay, like one patient is wearing a cap, like a huge cap. They might have like false visual field defect. Is it upper or lower? So one upper, right? Okay. Wonderful. I like the answer. Yeah, because this is a smart answer. So all except, yeah. So you have to say all are upper visual field defects except the upper retinal detachment. It will cause or might cause lower. So yeah, excellent. Why I like this answer? Because it's like more concise instead of typing 1, 2, 3 and so on. So it's really important to save time because the exam is quick, is super quick. Okay. So as you can see, patient, so I'm using here the color code. So all the above 4 result in upper, and upper retinal attachment cause lower visual field defect because the relationship, remember, the relationship is between the visual field, the object in the space, and the retina. Okay, but all the previous points, like before the, if we go back to this slide, okay, see here the intersection of the rays at the nodal point. Okay, so if we have a lesion here in the retina, yeah, the object, this object not seen, we have visual field defect. But if we have a lesion in the cornea in this area, so the inverse relationship is after the nodal point, after the nodal point. Okay, so, and if you remember, patient with severe ptosis, so you have to know this, patient with severe ptosis can result in upper visual field defect. And sometimes we need to tap the upper eyelid by plaster in order to do the test. This is an important step before ordering the visual field or during the perimetry, for example. Yeah, patient who's wearing a cap should remove the cap before doing the confrontation test. So imagine that they brought you a patient in the neuro station and the patient is wearing a cap. Okay? It's like wearing a spectacles. The patient should take off this cap, take off these spectacles in order to avoid fictitious or false visual field defects. So see how simple, basic information might help you in performing the test properly and avoiding unnecessary silly mistakes. Okay, so, and that's why this class is all about. Okay, another activity, nasal or temporal visual field defect. We have 1 and 2. Yeah, prominent nasal bridge cause nasal field defect, and that's why they sometimes advise to tilt the patient's face in order to avoid the false nasal defect. And nasal retinoschisis results in temporal field defect. Excellent. Now you got the idea, and I'm happy for that. Now let's make the illustration more complex and imagine that both eyes are open, because most of the time our eyes are open, both eyes are open. We have something called binocular visual field. And by the way, there is something called binocular visual field testing, okay? But keep it away right now, okay? Because this is, ignore this at the moment. So imagine now we have a fixation target. This is a star again. And by the way, the visual axis here are converging on this fixation target, and images are in the fovea. Now, be careful of the language, okay? Because if you fix it on target, you still see things around the fixation target, and this is called the visual field, by the way. So if we have a target here, this cross, this green cross, okay? It is in the temporal field of the right eye. And its ray is on the retina, okay? But at the same time, this green cross is considered on the nasal field of the left eye, on the nasal field of the left eye, and its image or its the ray is on the temporal retina. And if you remember the strabismus illustrated series, these points are the corresponding points. We call it corresponding points. The same on the other side. If we have object here, okay. Now write in the chat. I want you to practice using the same language. If we have this red square, it is in blank the field of the right eye. This object is located in blank the field of the right eye. Yes, nasal. So the ray falls on the temporal. And this is in the field of blank of the left eye. So this is in the temporal field of the left eye, and the rays on the nasal retina. Okay? It might be confusing, but if you look at the illustration, it would be much clearer, hopefully. Okay, one more thing. Remember, we have something big here in the middle, like a barrier here, which is called the nose, okay? So if we have object here in the far left, and as I said a few seconds ago, this ray is blocked by the nose. So you will never see this object by the right eye, but still you can see it by the left eye. Although both eyes are open, this object is seen only by the left eye. What we call this phenomenon? What we call this phenomenon? Both eyes are open, and we have object here is not seen by one eye, the opposite eye, but seen by the respected eye here. Yeah, excellent, excellent. Temporal crescent. Temporal crescent, something related to the visual field. This is a small area in the temporal field, because if you remember, this object is located in the temporal field of the left eye and is seen by the extreme nasal periphery of the left eye, and it is monocular by the left eye. This is called temporal crescent. Okay, again, this has an important implication later on. Okay, so just remember this phenomenon. The same applies if we imagine an object here on the far right. Object on the far right is seen only by the right eye. By the right eye, that is the extreme nasal periphery of the right eye, but you will never see it by the left eye because of the nose. Okay, so this is called the monocular visual field or temporal crescent. This object on the right side seen by only the right eye, despite the fact that both eyes are open. Another illustration, we have something called binocular visual field, but there is a wedge here or area seen by the respected eye, seen only by the right eye here and seen only by the left eye here. One more question. See this relationship, inverse and inverted relationship. Have you ever come across this relationship in other parts, like in ophthalmology, other than visual field? Because this explains the relationship between the visual field and retina. Yeah, excellent. Indirect ophthalmoscopy. Yeah, it's relevant, but I need another thing. But excellent. Yeah, the relationship between the image by indirect ophthalmoscopy and the retinal is inverse and inverted. We have another area in ophthalmology. We have this inverted and reverse relationship. And it's still relevant to the subject we are talking about. Again, indirect ophthalmoscopy is correct. The relationship between the image formed by indirect ophthalmoscope and any kind of indirect ophthalmoscopy, plus 90 or indirect, and the retina is inverse and inverted. Okay, I'm gonna answer it. This might help. If we have an object in the space and it's a retinal image, okay, and we have here four different possibilities, which one is correct? Which one describes the relationship between object in the space and its image on the retina? Yeah, the one who said B is the correct answer. Okay, so as you see, this is an apple, so I changed the star because you can't appreciate the relationship using the star, but here I use an apple, so the apple is inverted, upside down, but also flipped, inverse relationship. So this part, the black is becoming here, and this part is becoming here. the relationship between the image in the retina of the and the object in the visual field is inverted upside down and flipped left to right. Okay, nice. All right, now we finished we spent a couple of minutes. So compare my illustration to what the doctor said earlier. She just gave an excellent example that explains everything, but I want to make you interact and probably practice some of the skills to be observant, to think quickly. You really need these skills in the exam. Another statement, and I want one of you to volunteer and explain the meaning. You can type in the chat as well. And if you would like to unmute and share your answer. Visual field is a 3D and not 2D.
Madam, may I?
Yes.
Yeah, there's an entity called the Panam's fusional area, whereby you see the objects, they are perceived as a single three-dimensional point instead of a double. That is actually the concept that we see in visual fields. So it should be a 3D image that we see in a visual field, and not that is to justify why a visual field is 3D.
Okay, so imagine now during the exam. So you said, but still the examiner confused about your answer. So you have to repeat your answer again and try to speak slower, okay, and try to rephrase, and probably give me some examples or.
For example, a Rubik cube, where you have different color. Each side has a different color, like blue or red or green. So with seeing both eyes, binocular vision, you will be able to see the left-hand side of the cube as well as the right-hand side of the cube. So it's like the brain is made to combine the different images from the two eyes in order to form a single three-dimensional.
Okay, I got what you mean, but actually you are talking about another concept. So does anyone know what he is talking about? Or what did he explain right now? As far as I understood, he mentioned that the brain processing, because we have right eye and left eye, so the image from the right and left eye, yeah, exactly. So actually you are talking about stereopsis, which is another 3D, where we can appreciate the 3 dimension of any object in the space. And simply because two eyes are located horizontally separated in the skull. So each eye views the object from a different angle. So I think you are talking about the stereopsis, but this is not the answer for my question, actually. I am talking here about the visual field itself. Okay, so what you explained is actually the stereopsis, the meaning of stereopsis. So back to my question, the visual field is a 3D and not 2D. Does anyone have another answer? Yeah, so I got something interesting here. Okay, visual field is like hello vision, okay? Having depth, height, and width. Yeah, exactly. So, okay, the retinal sensitivity varies. So we view the visual field as something like, as the doctor said here, like hello vision, where the fovea shows the maximum sensitivity. See this arrow? The fovea is maximum sensitivity here, okay? And then the vision exponentially decreases as we go further from the fovea, okay? And if you are familiar with the Goldman perimetry, we have something called lines. You draw lines, and these lines have a name. Do you remember the name of these lines? Which join the points of similar sensitivity across the retina. Do you remember this? Yeah, isopters. Excellent. The sensitivity varies, so it's like a 3D, like a 3-dimension for the concept of visual field. Okay, it's not only you are seeing or not seeing. No, it's about more than that. So, for example, if we have an object here, okay, you might not able to see this object because it's dim. But if you increase the brightness, okay, you can appreciate. Or if you increase the size of the object, you can see it. Okay, so there is something more than just see or not see. No, it's related to the stimulus size itself and the duration of presenting the stimulus. And that's why, if you remember the Humphrey and octopus, so it's not only about 2D diagram. They mentioned the sensitivity of each point. So this is called a 3D concept. All right. And as you can see here, this diagram is very wonderful because it shows also the temporal extent of the visual field is wider. and followed by the inferior. And here we call it sometimes the cliff. There is a steep restriction of the visual field on the nasal side because of the nose. All right. And one more thing here, the blind spot, which represents the optic disc. It's like there's no vision at all. It's like no vision, okay? So there is zero sensitivity here. And so this is actually, we have scientists called Traquair who defines the visual field. There's an important, like a very famous description. It's a kind of poetic description of the visual field. He described the visual field as an island of
vision.
Yes, island of vision in the sea of, or surrounded by the sea of darkness or blindness. Okay, and he gave the blind spot a wonderful expression. He called the blind spot, physiological blind spot, a bottomless pit. It's like abyss, like no vision, something very sudden drop of the sensitivity. And see the flag here in the top, the peak of the sensitivity is the fovea here. And see how the nasal field is like a steep here, but on the temporal side, it's like gradual decline in the sensitivity. So this is a poetic description of the visual field by Traquair. Yeah, I just want to share with you. So always remember that we have to remember there is a fixation point, and then we have a limit for the visual field. So we have like, it varies, the numbers vary from reference to reference, but the visual field is 50, superiorly 60. So this is a nasal, and then inferiorly, and then temporally. It's like a spiral. Okay, this is one of the spirals on ophthalmology that you should aware of. Okay, mainly it is restricted superior because of the eyebrow mainly, and here by the nose in the nasal side, and the maximum visual field on the temporal side. And if you remember, the globe itself is least protected by the orbital rim. Okay, and that's why it's more susceptible to injury from the temporal side. This is a kind of correlation. So it's an advantage that we have a receding temporal orbital rim because it gives us more temporal visual field, which is really helpful. But at the same time, it disadvantages because it makes the eye more liable to trauma from the temporal side. Okay, so every benefit has like its own disbenefit or drawback. All right, so far so good. Hello.
Yes, ma'am.
Thank you. All right. So another diagram here shows the restriction of the nasal field. It shows also the reverse relationship on the retinal image and the object. Okay. And imagine now this object or this person is looking at this object. We have something called expansion of the visual field. So objects far from you, you can see more objects that are far from you. So you have something called coning or expansion of the visual field. Okay, and it has a more like an important implication later on in the following classes. So always remember there's something called expansion of the visual field, the binocular visual field. Again, this shows also the monocular field by the right eye here and monocular field by the left eye here. And you can notice this if you are like, you are sitting in the car, if you are the driver, okay? You can't see the person like sitting next to you, but you can see a wider view for far objects. So this again, to show you the expanding phenomena of the binocular field. Okay, and also for monocular field, by the way. But remember this photo, remember this photo. Second experiment, are you ready? Guys. Yeah. Say yes. Yes.
Yes,
okay.
ma'am.
All right. There is some kind of lag here, but anyhow, maybe because of the net. Okay. What do you think this experiment is about? Give me like your educated guess. So by the way, educated guess means guess based on knowledge, and most of the time it's correct. Yeah. So try to be more specific. So what do you mean by blind spot? You have to be, yeah, to be concise. This is really good, but at the same time, you need to be like clear. So If you are concise, like, and not clear, this is not good. I'm seeing it. So this is actually to test your blind spot. Okay, excellent, excellent. The one who said you are testing the left eye. So I'm going to show you some instructions right now. I'm using your laptop, but it works for those who are using their phones as well. Okay, so first of all, you need to close one eye. Which eye? Someone just helped us. You need to close your right eye. Okay? Yeah, right. So so first of all, you need to close your right eye. Number two, remember these instructions are really important when we are going to talk about the test itself in the next class. So you have to be specific. Don't say to the patient, close your eye. Which eye? So you have to say close, for example, your right eye. And then fixate. Yeah, excellent, excellent. Fixate on the red cross. Okay? And then, so if you are using your laptop, keep the laptop stationary and try to move from like closer to the laptop. Stay from out like far and come closer to the laptop until this black circle disappears. But if you are using your phone, it's much easier to move the phone closer to you until the black square disappears. Okay? And tell me what happens. Did it disappear at certain distance or not? Because you must have a blind spot, of course. Yeah, yeah, black spot disappears you have to at a certain distance while keeping fixating on the red cross while closing the right eye. Okay, excellent, excellent. Yeah. All right. So keep this distance fixed, okay? Because we are going to show you the next experiment at one moment. Yeah, at one moment. Now, keep the distance, all right? Now, there is a line. Is it continuous line or disconnected line? Continuous. Even there is a blind spot, the brain actually in the processing of information, the brain makes the line continuous, okay? Even though it's interrupted. Okay, again, close your right eye, fixate on the red cross, move closer or further from the screen until the black circle disappear, okay? And now the line should be continuous, right? Despite the fact it should be interrupted. I want someone to say yes. Yeah, line is continuous. And how about now? Now, do the experiment once more. If you do it properly, the line should be continuous as well. Okay.
Yeah, the
So,
line is
yeah,
continuous.
this is an
Yeah.
experiment to see that
Yes.
how the brain compensates for the blind spot, and that's why we can't appreciate the presence of blind spot monocularly, okay, and binocular, of course. So you need some maneuver in order to appreciate its presence. And of course, you know that's why we can't appreciate the blind spot. Now, coming to the last question regarding this point, when we have an area, let's say the physiological blind spot here, and this area, there is no vision. There is, yeah, but it's surrounded by vision, by normal visual field. What we call this area of defective vision. It has a name. Yeah, scotoma. Okay. And we have different classifications, excuse me, for scotoma. Is it, yeah, so someone say positive or negative. So blind spot, physiological blind spot, is it positive or negative? Negative, because we can't appreciate its presence, okay? Is it absolute or relative?
It's absolute.
Absolute, excellent. There is no vision at all. Remember, it's bottomless pit or abyss, no vision, zero sensitivity. Is it physiological or pathological? It's a silly, right?
It's physiological.
Physiological. But
Yeah.
but if within the normal dimension, because we have something called enlarged blind spot. Okay.
Yeah.
So the physiological blind spot is physiological within the normal dimension. Okay. But if you have
Yeah.
enlarged blind spot, this is abnormal. Why is
Yeah.
this important? Because we have a step in confrontation called mapping of the blind spot to detect abnormal large blind spot. Okay? Fine. Thank you. Sometimes they classify the visual field into central and peripheral. Other reference may classify it into 3 zones. But yeah, we can simply classify it as central and peripheral. So simply central is a central 30 degrees. So what's the meaning of central degrees? So it should be something called 30-degree radius. So it's 30 degrees from the fixation point here and here and here. So in every meridian, okay? So this circle represents the central visual field. And beyond this area is called the peripheral field. This visual field, by the way, is it of the right eye or the left eye?
Left eye. No, this is right eye. Sorry, right eye.
Okay, so yeah,
Right eye.
yeah, it's right eye.
Temporal is more. Yeah.
Okay, right eye. What is the blind spot? We have 4 different locations. What is the blind spot? 1, 2, 3, 4.
3.
1. Yeah, excellent. So the blind spot is between like 10 and 15 degrees. Okay, and usually depicted on Goldman like oval. Its dimension vertically is a little bit more than the horizontal dimension.
Yeah.
Excellent. So this is the right. You have to whenever, because in Viva they may bring the printout of visual field like Humphrey or Octopus. So first you have to say like, is it right eye, left eye, reliable or not? So this is like basics. If you say something wrong regarding the basics, it has like a detrimental like effect on your answer, on your score. So once the blind spot on the right side, this is the right field. And she said right field because the temporal field, this is a temporal field because it's much wider and larger than the nasal field. Okay. Yeah. And if remember this slide again, this is the blind spot. See the blind spot here within the central 30 degrees. When you're gonna test the blind spot, mapping of blind spot, so you are using the central field. So don't place the pen too far from the fixation target. It should be within the 30 degrees. For example, this is a kind of correlation between basic concepts and the clinical practice. There is a kind of classification for visual field test according to whether they are testing only central field or mainly central field or the peripheral field. So when it comes to confrontation, is it a test for central field or peripheral field or both? Both, excellent. And we will illustrate this in the next class. When it comes to perimetry, is it central or peripheral or both? Yes, both. So static, kinetic, automated, or manual, both. But we have some modifications anyhow. So we have 2 other tests for visual field, Amsler grids. And I mentioned here plural because we have like many charts, okay? But let's say Amsler grid. Is it for central or peripheral or both? Yeah, I like this out of the box answer. Yeah, central. Someone called it microperimetry. Excellent. So central. And how about the light projection? I'm gonna talk about the light projection test, and you have to differentiate between light projection test and light perception test. Okay? Yeah, excellent. All right. So Amsler grids belongs to central field test, and light projection belongs to mainly peripheral visual field testing. Why is this important? Because if you suspect a central lesion, you may have to use Amsler grid, for example. Yeah, just an example. And I'm going to share with you in the recorded version the link for description of the Amsler grids. But it's more relevant to retinal issues like age-related macular degeneration. Yeah, excellent. Someone said macular lesions. And you have to know how to perform the test because you are going to explain this to the patients themselves in real practice in order to monitor their central vision. All right, we are almost towards the end of the meeting. So you have to know the tools required in order to do confrontation test. I showed this slide from the first class in this series, okay? And if you notice here, better to have like red and white pen for confrontation test. So this is one of the requirements. Plus, you may have to bring your occluder to cover one eye, but the patient may cover their eyes by themselves, by their hands. And pen torch, I will explain the importance of pen torch for visual field testing later on. All right. These are the commercially available neurological pens, but it's not available in my area, so I needed to do it myself. So I already shared before, but I'm going to share it again in the recorded version, how I did the neurological pens. As you can see, one red and smaller, and one is white and bigger. All right. Others may advise using lancets for checking the blood glucose level. Like you can paint the tip using any kind of paint, white and red. Sometimes we may use a red cap of the psychoplegics. Even in our practice, sometimes we can use our finger. And by the way, in old books, like ancient books, they call it digital confrontation test. So digital back in the day means using fingers, but nowadays it has another meaning, totally different meaning, okay? The last part, this pen, I shared it in the first slide in this meeting. One of the interesting things that I found in one experience that actually the exam committee brought this pen in the exam. Okay, but this is not acceptable because it might be harmful for anyone. So we don't use sharp things while testing unless you are going to test the pain sensation of something. So don't use this. We have many other alternatives. And that's it. That's the end of our presentation. One last thing here is there is something called reflection. We always say try to rehearse, repeat information in order to memorize things, but there is something called reflection. So reflection means to like sit still and close your eyes and try to see what you've learned, what's something new, and what you still need to work on, okay? Especially if you didn't pass an exam before, you have to see your weaknesses and work on them and see your strengths and so on, okay? So I'm just asking you, all of you, if possible, to write down in the chat, is there something new you learned today or something was like interesting or useful? Just share with us in the chat. Okay, so any questions? I hope you found this class enjoyable and useful. Again, it's a kind of warm-up, as I said. We can end the meeting right now. Thank you all for your attention and see you again soon. Yeah, bye-bye.